All right, so let's keep going. So we had this patient who had right leg weakness. What do we think? What vessel do we think might be responsible for that? I think the answer is probably going to be the left ACA because of that right leg weakness. So from here at this point, we're going to think about what happens to a patient like this who's had a stroke immediately. So what are the things that we are looking for? Well, first of all, first thing we should know is that when we think about stroke pathophysiology, the first thing is that time is brain. So after someone has had a stroke, you really have to rush to get them taken care of because those neurons die very quickly. So as we can see here, that blood perfusion drops by about 90%, all right, very quickly in the center or the core of the stroke, all right? And then we have this penumbra area where there's still some preservation of the cerebral blood flow. And when we're trying to save someone's brain, as we say, or give a therapeutic agent acutely, we're really trying to save this area right here that we call the penumbra. So that's often the hardest to salvage, but that is probably the most important part because it gives our patients the best chance of recovery if we are able to save that. So we keep going. What do we think about when we think of an acute stroke? I think the most important thing for you guys to know at this stage, and even when you get into this a couple of years from now on your clerkships, is to always know the last known normal time. So when was the patient last completely normal? I think that is the biggest thing that guides our guidelines to potentially give patient thrombolytic agents. So what can we do in this stage? So we can try to reopen the blocked blood vessel, so clot lysis. The one thing you'll hear about the most is something called TPA, and that's most effective when it's given via intravenously, so IV, within 3 to 4.5 hours in some situations from that last known normal. There are other options that include thrombolysis intraarterially, actually mechanically pulling out the clot, or even stenting in some patients. And so here's just some examples of some historical things that we used to use back in the day. Now we have something that looks more like this particular device, but you can see the clot that we've just pulled out there, that nasty thing. So these things can be quite effective at what they do. So what does it look like when we are successful? Well, let's first talk about TPA. So alteplase is the other name for that. We will keep calling it TPA, but it does aid in the conversion of plasminogen into plasmin, and that plasmin leads to cleaving of thrombin and fibrin. So if this works and we're able to give this to our patients, we can get a blood vessel that goes from this. This was supposed to be the MCA, but it's a little stump right now. And if you give them TPA quickly enough, you can see that blood vessel open up nicely over here. This is a conventional angiogram where they're actually under live X-ray, and we shoot a dye into their arteries to watch and see where how the blood vessels look. So I'm going to put this slide up here. I don't want you guys to know every single detail of this, okay? But this is to give you a sense of what the specific guidelines are in order to give patients IV TPA. So you can see there's quite a few things here. Like I said, I think the most important thing to know for you guys is that last known normal time, right? So in most situations, 3 hours is the cutoff, but we can extend that time to 3 to 4.5 hours in specific situations. And some of the main themes here are basically, there are some things that can look like strokes but aren't. So if you have someone whose blood pressure is too high or too low, that might be a no-go. Or if they've had or they have improving symptoms, we might wonder if they're having a seizure instead. And then the other thing is if they're at a risk for bleeding, because we're giving a thrombolytic, and if they were bleeding already or are at a risk for that, then we're going to run into more issues. The bottom line, I think, is the right diagnosis and the right time, all right? And no bleeding.